Hello and welcome to Clinical Liver Diseases video series. CLD is an official digital learning publication of the AASLD. I'm Dr. Areej Mazhar. I am the Transplant Hepatology Fellow at Northwestern Memorial Hospital, and I am the author of Updates in Wilson Disease. This article basically focuses on the fact that it is difficult to diagnose Wilson disease because most of the tools that we use to diagnose Wilson disease are usually invasive in terms of a liver biopsy showing copper quantitation, or looking for Kaiser-Fleischer rings, which can also be nonspecific and can be found in other diseases like PBC and PSC. And unless you have a high suspicion of Wilson disease, it can easily be missed. This article reviews diagnostic and prognostic scoring systems that can be used to assist with diagnosis of Wilson disease. Some of those include the Leipzig score. There is also the, which is more of a diagnostic scoring system. And then there is also the revised or the new Wilson index, which is a prognostic scoring system that can also be used to see how these patients will do in terms of progression of their liver disease. In terms of diagnosis of Wilson disease, we do have, according to the guidelines, you need certain lab tests, certain exam findings, and the constellation of the symptoms is what helps you to diagnose Wilson disease. And some of those lab tests can be non-specific, such as ceruloplasmin is not specific for Wilson, and you can have low ceruloplasmin in protein-losing enteropathies and other chronic liver diseases as well. So the newer tests that have come out, which this article discusses, is the copper nuclear medicine IV bolus infusion test that looks at copper tracer and how it incorporates into ceruloplasmin at 224 and 48 hours after infusion. And then there is another proposed assay that this article also talks about called the relative exchange of copper, looking at the ratio of exchangeable copper to total serum copper after EDTA is added to the sample. And these two tests have shown very high sensitivity and specificity, approaching 100% for the diagnosis of Wilson disease, and they are non-invasive, relatively non-invasive tests compared to a liver biopsy, which can be used to diagnose Wilson disease. And finally, this article also touches on new gene therapy that is currently under investigation for treatment of Wilson disease. Currently, we are limited with oral therapy like D-penicillamine and trientine and zinc, and these therapies have side effects, D-penicillamine more so than trientine, which makes patients not very happy with taking these medications. There's also high rates of non-compliance because of difficulty with the dosing of the therapy away from meals and multiple times a day. So the new gene therapy, that this article talks about is specifically UX701, which is basically an investigational gene therapy using the adenovirus vector designed to deliver a modified form of the ATP7B gene as an IV bolus infusion dose. And so far, the preclinical studies have demonstrated that there has been reduced liver copper accumulation and increased ceruloplasmin levels, as well as improved liver pathology after administration of this medication. However, the final phase 1, 2, and 3 study conclusions are supposed to be published early in 2024, and I think the study will be entirely completed in 2031. But this is in regards to which dose of the medication should be used and what the monitoring should be. On behalf of all of us on the CLD team, I hope you found this video on updates on Wilson disease useful. For more information about updates in Wilson disease, please visit us at www.cldlearning.com. Thank you for watching.